Welcome back. It's been a long
Yeah,
4 years for all of us,
yeah.
I think.
Well, congrats on getting through training as well, right?
That's right.
Good,
Residency and a fellowship since we last spoke.
good for you.
Yeah, so I know that you've been busy. We've been following your journey, and I want to get right into it. I was actually going back to the archives and listening to some of our discussion. Just, what are some of the things that we talked about, and you had teed up a lot of things, and I know maybe it was foreshadowing, maybe it was just fortuitous thinking. But I want to start with maybe a bit of a polarizing topic at the risk of getting us all canceled right at the start. One of the things that we learned, we were talking about COVID, this was the midst of COVID. We had learned that probably COVID seemed to affect a lot of people with more of a metabolic ill health type situation, right? So, of course, vulnerable populations, we know about that, but people who had more comorbid conditions, excuse me, like diabetes, obesity, things of that nature, things that are right in your wheelhouse when we talk about lifestyle medicine and nutrition and eating and a lot of things that we talked about. Those are the people that were more susceptible to illness and more severe illness. And so, you being in this role of frontlines emergency medicine doc, where you saw probably a lot of people as they got sick, coming in, getting tubed, all that interesting stuff, but also the chronic disease burden, with your coaching business, what were some of the most impactful lessons you learned through this pandemic with that respect?
Well, thanks for the summary because I have no idea what I talked about last time. So, so thank you for that. Um, I guess let me be challenging a little bit and try to reframe because I don't like to talk about the pandemic as like a thing that's over. I like to talk about it as like an episode that really showcased like the flaws of medicine in our healthcare system, and I think continues to do so. And so I think my lessons are coming from that perspective. If I can shift just a little bit, I mean, I think our healthcare system was failing for decades before 2020, and I honestly feel like we were probably hanging on a straw for like a long time. But the breakdown of kind of communication, of consultation, honestly, of work ethic, of staffing, of like physician burnout, and like I think physician understanding of how our lack of autonomy in healthcare like really all came to a head and is ongoing. So I think I do have a few. I was thinking a little bit before the call about what my lessons would be, and I think my first lesson is probably that I have to earn my own wellness, and sometimes that means like saying no to things that don't serve me, whether that's in medicine or just in life, and it really means that I have to take the time to like serve myself because the job is harder and more complex and more challenging, and if I don't show up with my cup full, like I'm going to drown, which means that everyone else is going to drown, like my staff and patients and really everything. So I guess that's my lesson number one. I don't know if you guys have any thoughts on that or how that speaks to you.
Yeah, we always talk about you can't pour from an empty cup. I
Yeah.
think that's particularly for both of us who are recently, well, fresh out of training, where you have this mindset that you just have to sacrifice, sacrifice, sacrifice. I think the phrase is delayed gratification that we all get beat into us early on, right? You just kind of kick the can down the road and you get through residency training, although it's far better now in terms of ACGME and duty hours, etc. But you still have this mindset that you're just gonna grind and you're gonna sacrifice, and that also means sacrifice your health, not make your doctor's appointments, things of that nature, not take a sick day, because that might be burdensome on your co-residents and whatnot. But failing to appreciate that when you're not your best self, you can't be somebody's I don't want to say savior, but something that I've been starting to appreciate is that, like, some people come in their most vulnerable state to you, and you have to be your best self in the sense that you have to have a lot of empathy, you have to have kindness, you have to have understanding. And if you're not patient and you're not well fed and you're not well slept, it's going to be a lot harder for you to be a kind human being that can connect with people. So
Yeah,
that's
totally.
that's what I think about it.
Yeah, I mean, I'm a lot farther down the road of this career than you guys are. I think I'm probably a PGY 20. And I think I am. I mean, I think I really like held to the grind until just like a couple years ago, and I think I really did like hit a wall. I think some of that is because of what I just kind of kind of alluded to in terms of healthcare system burnout, and I wasn't feeling like supported anymore by my work environment. Kind of that grind like really hit me personally. So I think that was like really a good lesson for me as a lesson one, but also like if that can happen to me and like I do what I do and like coach about lifestyle health, it can happen to anybody. um, I think my lesson number two is that my profession as emergency medicine has always been, I think of like three things. Number one is, well, I guess two main things. Number one, like, let's make sure you're just uncomfortable and safe and not uncomfortable and dying, right? Like, rule out those bad things. And number two, let's make sure that there are next steps understood on where to go, what to do next after our visit together. And I think in the current healthcare system, I can still do number one well. Like, are you uncomfortable and safe, or are you uncomfortable and very ill or dying? But I think number two, the kind of what are those next steps is like now, like very, very hard to do. Like people can't get primary care appointments, or my specialists are months out. Patients are trying to figure out how to advocate for themselves to get outpatient care. And honestly, like many of them are not able to do that effectively for lots of reasons. I mean, I have an example of my mom was visiting me from back east. I'm in Idaho. She broke her foot while she was here. I knew it was going to be a possibly surgical repair, and nobody could see her for 5 weeks. And so it's like if I have to like pick up the phone and call and pull a doctor card to get my mom in for what seems like it should be easy outpatient care, what are our patients able to do? So I think I'm more of a realist now that I have to do more in the emergency department, which is a, not the cheapest way, and B, not the most effective way, because I am not those other specialists, right? Been having to like advocate for systems to help patients get that. So I think it's been a really big frame shift for me to like realize that things just won't happen for people once they leave. And that certainly makes things harder because it is easier to be like, well, we did what we needed to do. Like, you're not dying, or this is the illness that you have, and this is the plan that we're going to have, if you don't have the support from the rest of the healthcare system to effectively make that happen.
Yeah, Dr. Ace, you highlighted that COVID really brought out the inefficiencies of our healthcare system. You going through this for 20 years, you've seen it, but now you've probably even seen it zoomed in a little bit more, or things must have popped out at you. Out of the whole process of when it comes to, let's say, the messaging to when a patient comes to the ER, when it comes from the physicians taking care of that patient to the beds in the hospital to the infrastructure to the discharge, what have you now have a new perspective on? What has really jumped out at you during that entire process?
I mean, I think it's just some uncertainty. It's one thing to be like, you have to be admitted to the hospital, and oh, by the way, that means you're going to still be in room 18 for the next 20 something hours
Mhm.
instead of actually being admitted. But it's also that person sitting there while we're trying to give as much care to them as we can are not getting the same care as they would be in an inpatient bed, because my nurses are not med surg nurses, they're not neuro nurses, they're not ICU nurses, and people see coming in the front door, it turns out. And so I think, and then that other decision about like, we know that our hospitals are full mostly because of staffing issues that are not physician issues. um, but I also know that someone may not get the care that I thought that they should get in a quick time as an outpatient. So, am I admitting those people hoping they're going to get that care and then compounding the problem? And so I think that is like my decision making around admitting a patient is not the same as it used to be.
I was just about to ask that.
Simply,
Yeah,
yeah.
yeah.
Yeah, it seems like
Um,
a.
yeah.
Oh, sorry. Go ahead.
No, go ahead. I have another lesson I learned, but I would love to finish that
No,
conversation.
I was just gonna say, I wanted to ask you. You said that you feel like you have to do more in the ER now, but you kind of just answered that. It just seems like a very inefficient way to manage these chronic things. I mean, just when we talk about the global costs on the healthcare system, right? I think last time we spent a lot of time talking about what we can do as individuals, for as clinicians, as trainees, to educate ourselves and our colleagues, and to look at some of these quote unquote alternative therapies. And we talk about your background in Ayurvedic medicine and our experience with that kind of stuff. But when we look at the global healthcare system, we also look at the burden, right? The pandemic, as you mentioned, highlighted that. I later want to talk to you about the roundtable where I think the Senator Ron Johnson had people come up and highlighting the issues with our nutritional system in this country. But something that I've been really interested in is just looking at the cost of healthcare and the burden of healthcare. And we're always practicing cost efficient medicine. What tests are necessary to order, what are not necessary to order, and sometimes we get flack to our ER doctors for ordering unnecessary tests. But admitting patients just because you don't think that they are going to be cared for in the community, and even though this is not ideal from a financial perspective, but it's the best thing for the patient, that seems like a very difficult thing to cope with as a practitioner. And I can see like that's the kind of stuff that could set people up for moral injury, when you're thinking about
Yeah.
that.
Well, no, I mean, I think I just want to say that we get flack when we don't do the test as well. So
Fair.
just
Yeah,
gonna,
it's just that yeah, that's true
the
too.
retrospect goes both ways. But yeah, no, I think that we're being faced with the fact that maybe someone will need an outpatient MRI and they won't get it. Or, before, if there was a ankle fracture dislocation, I would have an X-ray, I'd reduce it, I'd discharge them to follow up as an outpatient. Maybe that they'd see the doc in the office and they decide if they needed a CT scan in order to like delineate a little bit more about what they need to do in surgery. But now I have to do that. I'm finding myself doing the CT scan knowing that it won't get done because they won't see the specialist in enough time. They may only schedule the surgery, and like not even see them in the office. And so even when it's not a decision about admission, it's a decision about what do we need to do that would have been done 5, 10 years ago differently than is being done now.
I think your mic might be off, or yeah, I don't know.
Sorry, Heather, I was saying we lost you there in the last 30 seconds. Can you say that last part again?
Sure. I was just saying that I feel like the decision's not necessarily. Can you hear me? Yeah. Okay. I think the decision point around admission or not admission is not necessarily the only one. It's like if I have someone who had an ankle fracture dislocation and I knew before they would just have an x-ray and I knew it was wrong with them, they'd be reduced, splinted, they'd follow up with ortho, they'd decide if they needed to do a CT scan or not before they went to surgery. Now we're just like having to do the CT scan for them because I know that they're not going to be able to be seen in the most efficient way and maybe only just like scheduling their surgery, if that makes sense.
Yeah, it does. So I like this thread that we're currently on. And I think one of the things that maybe for better or for worse has happened through this pandemic is, and again, this is one of the things that you called out. You said that patients are becoming more informed, people are becoming consumers. You mentioned last time during the pandemic, you tripled your business, right? The coaching business. Hopefully that's still thriving and even more so. And one of the things that we noted is that people really took to social media for better or for worse, right? The pandemic was a very polarizing thing. Vaccines, yay, vaccines, no. Who's getting sick? Who's not getting sick? But the other thing was that people started focusing on nutrition and the role of what we're putting into our body, how we're coping with stress, et cetera, et cetera. And what we saw was a lot of people were advocates for that and how that's really important for us to address and how that can contribute to just globally our health. And then we also had people on the other side that says, well, no, it's irrelevant. It's much more complicated. So I guess the question for you is, what have you gleaned from that social media messaging? You're obviously very active. And do you think the public health messaging, because of this pandemic, through this pandemic, has helped address some of these lifestyle issues adequately? Um, or is this or was it a missed opportunity to focus on prevention through metabolic health. Because what we've seen, as I mentioned at the outset, clearly that there was a strong correlation between metabolic ill health and how sick people were and the downstream effects of that.
Yeah, I mean, I guess a couple things to frame my answer to that. The first is I've been an integrative nutrition coach for a little longer than I've been a doctor, so a little more than 20 years. And so I've clearly always known that food, movement, and mindfulness played a role. And when I formed Wholist, it was because I realized that people were showing up at 3 a.m. with the adverse effects of the lack of lifestyle change from 5 to 10 years ago. So I knew this, but it's even more apparent to me now that there's only a few things that we can truly affect when it kind of comes to our epigenetics. And that is kind of, as you alluded to, how you fuel your body, how you move your body, and kind of how you react to your thoughts and feelings. So I think that that's just an important thing to know about like how I view all of this. I also have a master's in public health, so I have kind of thoughts from that perspective too. I think the one more thing in before I answer the question, and I will get to it, is that I think I knew that patients had some mistrust in physicians before 2020, but I don't think I really understood the breadth of it until the last few years, because I know that the vast majority of us as physicians and other healthcare providers went into medicine to help and to heal. And it was really hurtful, honestly, to realize that people thought that we were not in it for them. I think it was a good lesson for me to understand because I can, once I got over just being like insulted by it, I think it helped me kind of think about how I can change the way that I speak to people and understand their behavior more honestly and like to be a little more tolerant and opening to listening and explaining things differently. Like a very good example is um like why parents never give Tylenol or ibuprofen when they bring their kid in for a fever. And I was always like, I don't get it. I don't understand like why they wouldn't just do that very easy thing. But I realize it's because they don't think we're going to believe them. And my first answers was always like, well, why wouldn't I believe them? But that's not the problem. The problem is that like it's the perception out there in that we are not going to believe them. And I think that I think COVID, I think especially the 2020 and Delta when everyone was at home and the illness was really really bad. I think that that was where we really kind of figured that out. And so I don't know. I do think that I think everybody was right in your statement, Altamash. I think that it is important to pay attention to the things that we can control, right? Fuel, we know that making small strides in social connections and stress reduction and sleep, food, and movement, risky behavior modification, even just small strides in each of those, whether it comes to something like an epidemic we didn't see coming or when it comes to long-term chronic disease, is essential because those do lead to that spectrum of metabolic dis-ease, which is cardiovascular disease, cognitive decline, cancers, obesity, fatty liver, diabetes, hypertension, all that's related. I'm not saying anyone like did anything wrong if those things occurred to them, whether it was making them more sick from COVID or whether it's just something that's happened to them along the way because their epigenetics. It's just that giving ourselves the biggest leg up, so to speak, in those things on those things that we can't control by affecting what we can is really important. I don't know that the public messaging during the height of kind of Delta COVID, and I think it's important to make that differentiation about where we were at that time. Um, I don't think that it was focused on lifestyle modification, but I think that that's understandable and probably okay because people were scared and physicians were scared and the public health folks were scared. We'd never seen anything like this in our lifetimes. I do think that there were some of us talking about food and mindfulness and movement as giving ourselves that leg up when it came to disease mitigation, but in the moment, those things helped us feel like we were doing something when in reality the metabolic risk factors for people dying from Delta COVID were things that were 10 years before, right? Does that make sense?
Yeah, absolutely. I think COVID itself presented a lot of people to push their agenda. So, give you a quick example here. I was actually at a social gathering, and an advanced practitioner was actually telling my one friend how doctors are scam artists and how, to the contrary of not wanting to treat people, from the bottom of our hearts and actually do good in this world, we want to keep patients and we want to make money ourselves. And I'm almost positive this sentiment came from the last 4 years and what COVID had, quote unquote, revealed to the public, to your point about distrust. How do you feel about the messaging to doctors about how we should have discussions with our patients about whether it might be vaccines or treatments or pharmaceutical companies? Like, how did you have those conversations with patients as more and more news come out and some of them not agreeing with each other?
I don't, I mean, I don't think we were taught to have those conversations. I think, I mean, I can't speak to your medical school experience or your training experience, but mine was, this is what you should do.
Same. We're told
And
what to
I
do.
think that that's not necessarily um, how a constructive conversation happens between two adults in general, of like being very prescriptive and paternalistic. And I think I was like that for a lot of my career, of like, these just are the right things that you should do. And I think honestly, like expanding my coaching skills probably helped a lot in terms of being able to hold a space for how someone is approaching the relationship with you as a physician, and meeting them where they are and not judging them based on what their experience has been, to get them to bring them to the table. Now, am I going to say, yes, you should vaccinate your children, and yes, you should take insulin for your diabetes, and yes, you should move your body more, and yes, you should eat whole foods and those things? But the conversation needs to look differently based on the fact that people do feel that they're coming, and they are coming to that conversation with their read about information that they have gathered and their real experiences with the healthcare system. And I think it's a tricky thing for us to approach as physicians. I do think that um, I think that if we even, so the bigger picture is like, how do we help people understand how to take care of their bodies, listen to their bodies, understand how their brains work? Like, if our kids in I have elementary school kids, like if they started learning like how to take Tylenol, and like what it means when your stomach hurts, and what it means to get sleep, and like if they understood those things, if we understood those things going into medical school, these basic life skills, like how much better off would we be? If patients headed into adulthood like already knowing those things, how much better would we be if we taught these things in medical school, instead of like poo-pooing anything that we don't understand yet in medicine? Like, imagine, right? Our patients would be better advocates. They'd be less likely to fall for the BS online that's not real. They'd be in better metabolic shape. They'd be better partners in their healthcare. We'd be more open to like hearing the lifestyle things that affect them, and having those conversation about physical ailments that we may not really understand. So I think it's a big picture thing. It's not just healthcare. I think there's another whole conversation we could have about physician autonomy, and how if we took back our healthcare system and were controlling some of these systems that are causing this big problem that we're in, would be like, a whole nother thing. But I wish that we had more input into our education systems from a very early on.
So that's an interesting point, right, Heather? You said that we weren't really educated on how to have these conversations. I agree with you. Like, I mean, we're a little bit more recent than that. Medical school was pretty much the same. Residency training, fellowship training. You just don't have the time, right? So if you're going to input this into the curriculum, well, what's going to come out, right? When we're already overburdened, spend way too much time learning things that are arguably unnecessary, especially now you have the internet in your pocket. Then the question would become, well, who is the best person to have these conversations? So I don't know if you got a chance to look at the some of the stuff from the Senate roundtable on health and nutrition that happened a couple of weeks ago, where you had all these experts, social media experts, honestly. You had a couple of physicians on there, right? Dr. Casey Means, she's a prominent physician with the company levels. Dr. Marty McCarra from Johns Hopkins was there. There were a couple other people on there who have a lot of influence on the social media, podcasting, that kind of stuff. But what they're phenomenal at is these folks are communicating with the public. They have these platforms and they've done that. And they're actually, for the most part, I would say, put out good quality information. Nobody's perfect. And what I saw a lot on social media, and I just want to get your take on this, is a lot of people went and just started bashing these people, saying that they were not qualified to sit up there in front of Senate and talk about these key components about nutrition and our health, and just globally in this country, what we should be eating, how the policies should be happening, and whatnot. And Darsh and I had this conversation on the side and said, well, who is the best person to talk about it? Is it physicians? Because we're not, as you mentioned, we're not equipped to be having these conversations. You said that you had a coaching background prior to going to medical school. So you were trained, outside of this, and that's why you're so good at what you do now, and you've honed that skill over the last 20 years or so. So, part one of the question is, are we even the right people to have those conversations? At like a macro scale, not inside the patient rooms one on one, but when we're talking about systemic change, because that's where we started this conversation, are we even the best people? And if we're not, then who should be having those conversations? And the second part for you would be, if we are going to be the right people to do it, and we're going to implement this into medical curriculum, what's coming out? I have some thoughts to that, but I'm curious what yours are.
I don't know. I mean, I think that physicians are a very diverse group of people, right? I mean, what you're an expert at and what Darsh is an expert at and what I'm an expert at are all very different based on what we took out of medical school and what our training was and what our specific expertise is. So do I think that this conversation should come from any physician? Not necessarily, but I do think that there are a subset of physicians that are very well trained in all of that, and that is, preventative medicine, lifestyle medicine, obesity medicine, and it's bringing in our colleagues who are dietitians and nutritionists and personal trainers and figuring out kind of how to work together. I think the more complicated question is do people in our society want to listen to people who come with expertise? And I'm feeling pretty discouraged about that these days. In that I think that there is general mistrust of someone who comes with a particular amount of education or expertise. And I think I mean, I mean, why are these people getting on and bashing these very high level, very interesting people with diverse educational backgrounds who are providing good information for us? Because that's what people do on social media. And I think that's what people are doing in general over the last 5 to 10 years in a growing way. And so it's not an answer. It's just saying that, like, I think we have a long way to go to getting people to trust various levels of people.
Follow up to that, define expert with respect to nutrition. Is it somebody who's a dietitian? Is it a nutritionist and a PhD level in nutrition? Like, who is that, right? Because some of these people that I'm talking about, um, for instance, there was one individual on there, and I don't think he has any formal credentials and education in nutrition, but a deep interest, and has written a couple of books about it and talks a lot about cognitive health. Heck, everybody knows I'm talking about Max Lagorbe at this point, right? And I think he does a phenomenal job. But a lot of people bash him and saying, okay, he's just a quote unquote podcasting bro talking about nutrition, because I think he's a journalist background. I could make the argument that somebody who has a journalist background has the ability to do deep research and really educate themselves on these topics. Now, somebody who's spent 10, 20 years self-educating, researching, putting out documentaries, is that the expert? Or somebody who has a PhD after them, they're automatically expert because they have these, conventional credentials.
I mean, I think they're both experts in their own way. I think the question is how do we source out the person who got the PhD who's an expert but doesn't have any real world experience, uh, in or the kind of expert without the credentials who is peddling their own supplements and not providing as expert opinion. I don't know that person in particular that you're speaking about, but just in general, like, I have people on my staff for here at Wholist who are kind of our food and weight coaches who may not be a dietitian. And while dietitian is kind of the most credentialed that you can be within nutrition, because in the nutrition world there's lots of ways to come at that word um, but these people do have a wealth of information, sometimes more than I do, and I trust what they're doing. And I think, again, kind of a non-answer, but like, people come at their information from all sorts of different ways, and I just wish that as a society we had the capacity to be able to do our own investigative kind of critical thinking into the information that we're receiving in a way that we can understand what is real and what's not real. Like that person that you're talking about is I agree with you, an investigative journalist, like those people can figure out any topic. And maybe that's something we all should be learning kind of how to do when we do our own kind of data researching, you know?
Yeah. If I can add here, I think it's so difficult to try to become an expert with nuance in today's world, right? I think in order to get to the stage of where these people are at the Senate, in order to have a mass following, you have to create a niche. You have to create a quote unquote cult, I feel at this point. You need people to form a camp with your idea and your agenda. And I thought about this a lot as a physician. Us three come at topics with nuance, and so it's difficult for us to quote unquote create a brand where people are going to only just follow us. So I try to outsource as much as possible. And I think as a doctor, our importance is still there, right? In this country, people value our opinion. People still come to us with secrets. And our truths essentially is what they want to hear. And so ultimately, to kind of answer your question about whether are we the right people, I think you have to match importance with importance, right? I think that's how you can really start to get people to follow a message. And I think it's difficult though, when you have this distrust, right? If we link it back to that. And the other part of this is how do we get the lifestyle factors, the things that we know are important, to be important to the rest of the public? So I don't know. It is kind of a chicken or the egg situation for me. It is difficult to try to get that messaging out there. One of the things I try to do with my patients is give them the resources and say, hey, this is why I trust this influencer. This is why I trust this person. Do your own research, but try to come at it with nuance. And I think trying to teach our patients about nuance is one way that they can go and kind of do their own research and feel empowered. But I don't know. It is tricky.
I mean, like on a systems level, right? Like what we're talking about is trying to create a lack of a better word, a clinician led multi-system approach. So you're talking about trying to figure out how education and legislation and payers are coming together to fund, because that's what it comes down to, is money, to fund the things that are going to be the best for our patients and for our communities. And that is going to be funding things that affect things 10 to 15 years down the road. And that is coming up with a way to have at every level in the healthcare system a team of people that everyone is their own expert, right? Like I don't know all the things. And that's why I have a team here at Wholist where I have a hypnotherapist and I have the dietitian and I have a trainer, right? It's like those things are not me. And if I can out kind of delegate those things so that they bring their expertise, then we're helping that patient the best. Can we do that on a hospital system level? Can we do that from a legislative perspective? How do we convince the insurers that they should be paying for something like that instead of just procedures? And it's all very complicated, but I think what it comes down to is, you're right, is bringing different experts to the table at every level and being collaborative about what we know and we don't know and how we can all be better together.
Yeah, I think, I go back to something I've heard Dr. Matt Ramsey talk about. He's got a really cool podcast. He's a local surgeon here. He talks about how at the center of this entire ship has to be the provider and the patient. It's centered around that, right? I mean, of course, if we're talking about at the mass level, then it might be multiple patients or however many groups of individuals that you have, but it always comes back to that interaction. And I think the challenge becomes when the systems and the payers are led by administrators who don't understand clinical medicine, who don't understand patient struggles, who don't understand the pathophysiology of disease and the role of all these, including non-nutrition and lifestyle related issues that could be contributing, right? So I think as a clinician, you've been educated and you can really balance where pulling on the lever of nutrition, stress, sleep, that kind of stuff is more applicable and it's going to make more of an impact on somebody's disease or health trajectory versus it's not. And it's funny that we're having this conversation today. I just came across a paper that Dr. Beth Frades had reshared on LinkedIn, and this is hot off the press. So published in JAMA Network, it's open access for everybody, and the title is "Proposed Nutrition Competencies for Medical Students and Physician Trainees." It's basically a consensus statement about the of 36 physicians or 37, I don't know, but experts, all subject matter experts in the field of nutrition and health, and obviously medicine, come together of the things that are necessary for us medical providers to learn through our training that are going to make an impact in overall kind of healthcare costs. So I will we'll link that in here and I'll send it your way because I know that
Yeah,
you probably
she's
know
great.
Dr. Frades. Yeah,
Yeah.
she's phenomenal. So I guess on that thread that if I think about aside from this paper, if you've obviously given this a lot of thought. You said you're got the education in public health, you've got the coaching experience direct, you're a physician, you're frontlines, you're practicing acute and chronic healthcare for 20 plus years at this point. You know, other than the things that we've talked about, and as we reflect on everything over the last 4 years of how that's amplified, but really you said 10, 20 years prior to that, we've seen how diabetes and obesity didn't get to be 43 to 45% of America over the last, like during COVID, right? That's been building up, as you mentioned. 88% of people having one criteria of metabolic syndrome that was published 2 years ago. That didn't just happen during COVID. So as you reflect back on this and thinking about lifestyle and integrative medicine and things and preventative medicine, um, how do you or what advice would you give to healthcare providers and public health officials on integrating these alternative things into our everyday care moving forward?
I mean, I think I sort of covered it. I mean, I think it's trying to think of it not just on a micro level of what you're doing with your particular team or your clinic or your department, but it's trying to get more people with different expertise coming together at a systems level. Because I do think that this is not just medical education. I think it's general education. I think it's getting people to understand that science has a role. It's getting people into legislature. I mean, you have to understand I'm coming from Idaho, so this feeling very particular ways around the legislatures making decisions for our physicians and our patients. It's getting on every level into a way where people are more collaborative again and understanding each other, and not taking everything so personally if someone feels differently. I don't know what the answer to that is, besides the fact that for the last 20 years, I keep putting my hand up to do education in various different ways, whether it's this or whether it's, statewide or whatever it is. I think that more of us need to be doing that, whether it's coming from a public health perspective or physician perspective or education perspective, to be putting our hands up. And it's very easy to feel very disillusioned where we are right now and saying, well, I'm fine. Everything right here is just fine. So I'm just going to think about this. And I think that feels safe, and it feels hard to put your hand up to be noisy, to make things better. But I think that we just need to all be doing that more.
Let me ask you to zoom in a little bit then. Okay,
Mhm.
and maybe some of this is selfishly, I kind of need to know from somebody who is a little bit more seasoned than I am and experienced that everything we talked about at our systems based level, that change is going to take a long time. Okay, we understand that. And we've also highlighted multiple times is, for folks like us who understand that nuance, who understand the value of this, but because of the way the system is currently set up, aren't able to practice according to those values that we have, those internal values. And also the understanding that the science is very clear of where it's helpful, where it's not helpful to focus on certain things, but because of limitations, whether it's insurance, coverage, etc., you're not able to practice the appropriate way that you think is appropriate. Those types of things create moral injury, and I think a lot of times people confuse that to be burnout, like lack of autonomy, your care being dictated, and barriers with insurance not approving the test that you need, as you've highlighted before. But then also just not being able to practice what you think is the quote unquote right way to practice. How would you advise a younger clinician, perhaps Josh, perhaps myself, to put your head down, be patient, and not let it burn you out, not let the frustrations get to you, because that change is coming, right? I guess, how would you advise somebody like that to be hopeful that that change is coming?
I do think I've seen huge changes in the last handful of years on a systems perspective, like the Take Medicine Back movement, the direct primary care movement, the direct specialty care movement. I think that there's a lot of opportunity to let us know that things are getting better. From a personal perspective, I do, and this sounds like I'm kind of preaching to the choir as we've been talking about, but I don't think you can stay healthy emotionally and mentally as a physician or as a healthcare practitioner without taking care of yourself. And I think I'm not like going to be talking like the administrator saying that you need to do yoga and be more resilient, but I'm just saying that concentrating on the things that you can control, which is your food and your movement, and whether your thoughts are real and your feelings are real or if they're just there, that those things can really bring you to that patient encounter in a much more open way. If you show up unslept and over caffeinated and poorly processed food and not having kind of dealt with your own movement or emotions that day, you are going to have a very small wall to be able to have a constructive conversation. And I think that every patient interaction is the only thing that you can control. And so, yes, you may be in a job or in a career path that you chose that is currently has you in an employed position that you have 15 minutes to see someone and you're 30 minutes behind and you aren't going to get paid for X, Y, or Z, but there is the opportunity to sit down and really look at that person and try to hear and try to have an open conversation about how you think that your expertise could give them more information to be better. And I think that those are the patient interactions that you can control. For those people who are in a type of medicine that they have flexibility, like I would really suggest talking to people about what it means like to go into direct care model and to start removing the layers of control from non-clinician administrators and payers and all of those other things and really get back to that patient doctor relationship. And I think I mean, that's obviously not something I can do in emergency medicine, but a lot of people can. And that's been what Wholist has brought to me, is like I've been able to like have that relationship with people in the way that I think that it needs to, and talk about these things and still get paid for it. And I think that that is what a lot of our physician colleagues who are expanding into that sort of model, whether it's direct specialty care, direct primary care, are really able to do. Does that answer your question?
Yeah, we're definitely seeing a lot more of those models. Obviously, COVID has brought out more burnout than ever, right? In physicians. Now, do you feel like there's actually more of a tighter control on physicians from administration, or do you think there is at least some hope of recognition of wellness? Forgetting about the wellness lectures, do you think there is some more understanding about what physicians are going through right now from administration?
I don't know if I'm in the kind of practice setting that I would be able to answer that as well as you would like, to
Hmm.
be honest. I mean, my group is a physician-owned multi-specialty group. I think because of that, we're very unique, and we've always had each other's backs because the company is physician-owned, and we
Right.
contract with hospital systems to provide our care. And so I don't have that same touch kind of within
Yeah.
some of the hospital-based systems as others do. I would hope that it's the case. I think the conversation amongst physicians about understanding what secondary moral injury is was never something you would have heard 5 years ago. So I think just
Right.
having that conversation amongst ourselves and have that being language that we understand, having it more clearly understood that physicians want to be called physicians, right? Even just something like that was not a conversation 5 years ago. the conversation about training matters and that everyone's role on the clinical team should be understood. Those things were not understood. Those things were not talked about 5 years ago. So I think just us having that conversation is going to eventually lead to system change, but we need to have the conversation in a constructive way, and the fact that we're not making enemies out of our colleagues who are in administration.
I love that. Well, Heather, thank you again for being patient with my technical issues and dealing with all this thing. We're shaking the rust off. I think I just want to highlight something that I had to remind myself early in my career. I think, and particularly for the young trainees, Darsh, maybe even for you because you just started. I think we always have to remember that our everyday can be somebody's best day, right? Or the most important day in their lives. And you probably in emergency medicine see this multiple times a day, right? Because you're with the type of things that you're doing. And I recently had this happen about 2 weeks ago where I had multiple of patients in a row where they were really going through some difficult time and some impairments in quality of life, and I had made them better pretty acutely in the clinic, and they left feeling much better. And multiple patients actually broke down because of how impactful or the lack of function, the lack of ability that they had because of the pain and struggle that they had. And so I that was a day for me to kind of, at the end of the day, I felt rewarded. I felt like, oh man, today I made a difference. But the reality is, and this is not me trying to pat myself on the back, the reality is that's probably happening once or twice every single day, but you just don't think of it because you're running one patient after the other and you just kind of don't have time to reflect on that. And so I think that can be an antidote for going through this when you are struggling and you're thinking about, man, I don't really feel like this matters. What I'm doing is if to kind of reflect back and say, okay, actually, there are those interactions, that one to one behind closed doors, that you're having these deep conversations when patients are sharing the most vulnerable things about their life, and you're actually making an impact. So I would encourage my colleagues, as we're awaiting this big shift and change to happen, is to kind of just focus on those. And so with that, Heather, the last question, and I actually don't remember what you said last time about this, is we're big about adding the health back to healthcare. That's kind of our tagline here. And so when you think about that phrase, adding the health back to healthcare, what comes to mind for you?
I think I probably said this in some way throughout the last 45 minutes, but I do think that health is not just a lack of disease, but it's the ease of the collaboration of different systems in our bodies. Like, I'm not a religious person, but I am every day astounded that we could grow humans inside of us and so many of them are born fine, right? And the more that you dig into the physiology of like how our body even like takes in food and metabolizes it and processes energy and expends energy into every cell in our body, how our gut like helps our brain and our brain helps our heart and so many more and more complex systems, it's really astounding. And I think our goal as patients and our goal as physicians should be to try to figure out how to live our lives like fully and satisfied, but also use the tools of food as fuel and thoughts of suggestions and movement to support our body to like do what they were meant to do and give us the best chance that we have to like avoid the errors that lead to metabolic unhealth. And I think the more that we can get people to make those changes, which seem like at first you want to blow them off, right? Like, oh, I should sleep more, or I should drink less, or I should move more. But they are really the essentials of how we keep this complex, amazing body of ours moving forward. And I think the more that we pay attention to that and talk about that, I think we're all going to be better.
Yeah, that's well said. I keep learning this. There's no such thing as solutions, but only trade-offs. And I think even COVID has taught us this. It's, given us the opportunity to have these important conversations with important guests like yourselves. And so one of the things that we keep learning is the importance of everything you just talked about. And I actually, the last time you answered that question, you talked about control and how we have control over ourselves and our
Mm,
decisions. So everything definitely goes hand in hand, and appreciate having you on here. So thank you.
Thanks for having me.
thanks, Heather.